Welcome everyone for the class on miscellaneous topics on musculoskeletal. So it is a part 3 of musculoskeletal miscellaneous topic. First one, what we'll be looking at is the compartment syndrome. So what is compartment syndrome? Why does the compartment syndrome occur? If you consider this as a cross section of your limb, either the upper limb or the lower limb, there is some pressure which is exerted either from the externally. From externally, there is increased in pressure is present. For example, there is a cast which is present, which is causing more pressure on your compartment, that is on the cross section of your upper limb or the lower limb. Or there might be an increased pressure from inside the compartments itself. For example, it might be because of the swelling which is developing, the edema which is developing. Whenever the pressure increases, what happens when the pressure increases? There will be arterial compromise. So arteries will get constricted, or basically there will be pressure on the arteries resulting in compromise of the blood supply to that particular area. That will result in something known as compartment syndrome. Compartment syndrome usually presents with symptoms which can be easily remembered with 6 Ps. But the most important one is the pain what they are complaining would be out of proportionate to the injury what they are having. They are having severe pain. The injury looks very minor injury. And on passive stretching, the pain is worse. This is very typical of compartment syndrome. This is one of the first signs which appears in the compartment syndrome, multiple times tested in the previous diets. So you need to be aware of this phrase, which is very important. The more earlier signs are paresthesia and poikilothermia. What is paresthesia? Abnormal sensation. Poikilothermia, cold. Okay, they're quite early, but not as early as the pain out of proportionate to the injury. They're quite early. The late signs are the paralysis, where they are not able to move their fingers at all or the toes at all. Loss of pulse, pallor. Those are late signs. It takes time to develop. Hours together, it takes time to develop. The earliest sign is the first one, what you need to remember. After that, paresthesia and poikilothermia. What are the investigations what are required? The most important investigation what you need to is to measure the compartment pressure. So you have a bedside device, you can easily measure the compartment. So what is the compartment pressure? Usually the compartment pressure is between a 0 to 8 millimeters of mercury. That is the normal range of the compartments. If it increases, you need to take a reading how much it has increased. Then what you will be doing? You have the diastolic blood pressure, subtract it with the intracompartmental pressure. The value you are getting it, if it is less than 30, that is the indication to go ahead with fasciotomy. So that is the importance of measuring the intra-compartment pressure. So whenever they ask you what is the next best step when you're suspecting a compartment syndrome, to measure the intra-compartment pressure, because you want to see whether there is an indication to go ahead with the fasciotomy or not. It is the initial state, you can manage it medically or requires an fasciotomy. That decision will be taken depending on the intra-compartment pressure. Once you have the intra-compartment pressure, you will be subtracting with and diastolic blood pressure. If it is less than 30, you'll go ahead with the fasciotomy. Along with it, what you are getting it done, urine dipstick you'll get it done to mainly see whether there is myoglobinuria is present. CPK values, because muscle breakdown will be there whenever there is increase in intercompartment pressure. Whenever these muscle breakdowns are there, renal function becomes important, because the renal, it affects the kidneys. It can cause acute kidney injuries. So fasciotomy is the treatment what you need to remember. It is very important. Fasciotomy is different from sclerotomy, what we have already learned in our previous classes. Sclerotomy is done only in the burn cases when there is a third-degree burn which is causing a constriction. Is a charred skin which is causing constriction, preventing for the expansion of the swelling which is developing, or preventing the chest expansion so cannot breathe. So you're making an incision up to a depth of subcutaneous tissue. That is known as sclerotomy. That is different from fasciotomy. In fasciotomy, you basically dissect and remove all the dead tissue, and possible amputation also might be required here. So fasciotomy is the one treatment of choice for the compartment syndrome what you're doing. Sclerotomy is only meant for burns, especially third-degree burns. So there is a differentiation between sclerotomy and fasciotomy. What are the complications of compartment syndrome? It is very easy to remember. You remember this is as a muscle cell. Okay, muscles break down because the intra-compartment pressure has increased. Once the muscle has broken down, there is a lot of potassium inside the muscle cells which gets expelled out. So you will be seeing hyperkalemia. This myoglobinuria or myoglobin what is present needs to be excreted out. It has broken down. It needs to be excreted out. It gets stuck in the kidneys. Whenever it gets stuck in the kidneys, it causes acute renal failure. That is the other complication what you are having. The last one what you need to remember is hypocalcemia. Why hypocalcemia? calcium goes and deposits on the broken muscle what is present. Okay, so rhabdomyolysis, renal failure, hyperkalemia, hypocalcemia, because calcium is depositing over the broken muscle what is present. What about hypovolemia? Water gets sequestrated or gets in gets kind of enters into this broken cells, resulting in hypovolemia. So these are the few complications which are very important, what you need to remember. Obviously, there will be some compromise on the nerves, so neurological deficit will be there. If the condition is worse, then amputation might be required. Sometimes even death can occur. Ischemic contractures can occur like this because the muscle has gone into the spasm because of the increased pressure. Local infections predisposed to the infections because blood supply is compromised there, so your protective cells like WBCs cannot go there, resulting in local infections. These are easy to remember. This part can be remembered with the explanation what you are given here. So in this manner, you need to remember. Remember that muscle fiber gets broken down, potassium gets spilled out, calcium gets deposited over the muscle fiber, along with the water gets sequestrated into the broken muscles. That's how the complications occurs in end compartment syndrome, which is nothing but similar complications what you see in rhabdomyolysis. When we are learning in the nephrology chapter, I'll be repeating the same thing. Septic arthritis. Septic arthritis we'll be studying again in the pediatric chapter where we'll be learning about the Kocher's criteria. Kocher's criteria is mainly applied in the pediatric age group rather than in the adults. So we are not learning Kocher's here. We'll be learning in the pediatric. What is septic arthritis? Septic means infection. Arthritis is inflammation. Inflammation due to an infection here has happened. How does the infection enters into the joint space? Either directly from the blood, so that is the most commonest, or direct some injury has happened, like an punctured wound, gunshot injury is there. So the infection has directly entered into it, or from the surrounding structures. Surrounding structures like overlying the skin, if it is infected, it can enter and or it might be underlying bone which is infected, so it has spread to the joint space. So surrounding structures or from the blood or direct inoculation. Most commonly, it comes from the blood. Which one of the following is the most common organism multiple times tested previously? It is the Staph aureus. What do you need to remember? If it is less than 2 years age group, hemophilus, what do you need to remember? If someone is sexually active and you're having a very active lifestyle, multiple partners are present, then gonorrhea becomes the commonest one. What you do in the emergency department? In the emergency department, you treat this as an sepsis. So septic arthritis is equivalent to an sepsis. What do we need to consider? Basically, what do I mean by this is it is a severe infection. What do you need to consider? So you cannot discharge these patients. All these patients needs to be admitted. You cannot discharge. Once you are admitted, or once you're taken a decision, this is septic arthritis or you suspected septic arthritis, do and joint aspiration. Send for synovial fluid analysis. Synovial fluid analysis for both culture as well as just the analysis what you'll be sending for. In analysis, you'll be looking out for the inflammatory cells. In cultures, you'll come to know which organism it is causing it. Inflammatory markers, blood cultures are required. If you're suspecting an osteomyelitis, then get an X-ray also done along with it. Start with intravenous antibiotics, flucloxacillin. One thing what you need to remember is you shouldn't start the antibiotics before you do and joint aspiration and collect the synovial fluid. The main reason is if you start the antibiotics, then do and synovial joint aspiration for synovial fluid, it will not come positive or you'll not be able to isolate the causative organism. For that reason, always do and joint aspiration before you give the intravenous antibiotics. Otherwise, the orthopedics will not be happy with you. Analgesia for any pain you will be giving needs an orthopedic referral, basically needs an admission. IV antibiotics needs to be given. They might take a decision to irrigate and drain, put a drain in, irrigate the joint space, depending on how severe is the infection. That call will be taken by the orthopedics. Your job is to do and joint aspiration, send the blood investigations, what you send for in sepsis. If you're suspecting an osteomyelitis, get an X-ray done. Start on the antibiotics, refer to the orthopedics. The preferred antibiotics is flucloxacillin, mainly tested in the primary, but can be tested here also. So remember the name flucloxacillin dose is not important. Gonococcal arthritis. Gonococcal arthritis means basically septic. It is a form of septic arthritis. If it is caused by gonococcal infection, we call it as a gonococcal arthritis. So gonococcal arthritis is nothing but in septic arthritis. That's one kind of presentation. There is another kind of presentation also which can be presented because of the gonococcal infection. This is known as arthritis dermatitis syndrome. So there is an arthritis. Arthritis is migrating polyarthritis. One time it is a knee joint, next time it is an ankle, next time it is a shoulder joint. So it is migrating and it is involving multiple joints. It is involving and it is causing inflammation. That's why we call it as a migrating polyarthritis. Along with it, there is an rash which appears in this manner, what you are seeing here. There is an rash also, it will be associated with it. That's why it is known as dermatitis also. And it also involves the tendons, the sheath covering the tendons. That's why it is known as tenosynovitis. So dermatitis, tenosynovitis, and migrating polyarthritis can be present. This is an second presentation. So two types of presentation, just in one joint is involved and it is nothing but septic arthritis. What we have learned here is the same thing. No changes at all. Another form is arthritis dermatitis syndrome, where it involves the skin and sheath covering the tendons and involves multiple joints. Sometimes it might be shoulder. After a few days, it is the knee pain. After a few days, it is the ankle pain. That is known as migrating polyarthritis. In a single time, there are not multiple joints. It is migrating. Over the time, there are multiple joints which are involved. It is an infection, so needs and broad spectrum antibiotics. Usually, admission might be required. Okay, most of the time, admission is required here. You need to admit this patient. Osteomyelitis, again, very important topic here. Multiple times tested in the previous diets. In last diet also, there is a question which has come on the osteomyelitis, which is kind of a recall question itself. What is osteomyelitis? It is the infection of the bone, either by the bacteria or the fungus. So it is an infection of the bone. Most of the time, it is the bacteria which is causing it. Most of the time, it is from the surrounding structures. For overlying the skin, which has got infected, then enter into the bone. So our joint space, septic arthritis, eventually resulting in osteomyelitis also. Most common organism like septic arthritis, it is Staph aureus here also. Overlying skin, the joint space might be warm and there might be some swelling, some redness might be present, sometimes may not be present. Radiologically, early signs in the course might be completely normal. You might not see anything. So early signs are not present. But later on, there might be multiple signs which can be present, which are very important. There might be periosteal elevation. This is known as periosteal elevation. This, what you're seeing, is known as periosteal elevation. This is also known as periosteal elevation. So you know how to pick up an periosteal elevation. Whenever there is a fracture, when it is healing, there also you can see an periosteal elevation. But depending on the presentation, you need to take a call whether it is an osteomyelitis or a fracture, what you're. Along with this, you can also see an lytic lesion. What is lytic? Breakdown. So breakdown of the bone. Whenever the bone is broken down, air enters in, it looks more blackish in color. Broken down of the bone, air enters in, looks more black in color. That is known as lytic lesion. So lytic lesion, periosteal elevation are the two important signs which can be seen. MRI is the preferred modality and bone biopsy is the definitive diagnosis. Definitive diagnosis you want, bone biopsy is the thing. Imaging, preferred imaging is MRI scan. But most of the time we depend on the X-ray because it's the cheapest and easy to get it done from the emergency department. MRI is not at all easy to get it from the emergency department in NHS. For that reason, we still depend on the X-ray to make a diagnosis. We all admit any osteomyelitis like septic arthritis to get broad spectrum antibiotics. You need to admit them under the orthopedics. Gout. What is gout? Gout is basically increase in uric acid levels and it gets deposited in the joint spaces. Especially it gets deposited in the first metatarsopharyngeal joint here at the toe. Basically it gets deposited. These depositions can be seen in various areas, sometimes in ears, fingers, toes, elbows also can be seen. It is known as toe feet. What are the causes for increased uric acid increased production of uric acid? It might be because of increased alcohol consumption or increased protein consumption itself, because uric acid is a byproduct of proteins. So increased protein intake can result in increased uric acid levels. Increased breakdown of the muscles. Your muscles are nothing but proteins. Cytotoxic drugs results in breakdown or basically cells, sorry, not muscles, cells that can cause myeloproliferative disorders, increase production of the cells. Again, cells are nothing but proteins. Proteins breakdown will result in uric acid production. Trauma, exercise, breakdown of the muscles in trauma and exercise results in uric acid, increased uric acid presentation. Decreased secretion of uric acid is the another pathophysiology where there is a decreased secretion. That's why there is increased amount of uric acid in your blood. Sometimes, or most commonly, you do not know why there is a decreased secretion of uric acid. That's the most commonest cause. So it is an idiopathic cause for decreased secretion of uric acid, most commonest cause. Some enzyme defects might be there. Some drugs like diuretics can cause it. Renal failure, obviously, your kidneys are not functioning properly, uric acid levels will go high. What is the investigation? Investigation is you will do an joint aspiration and send for synovial fluid analysis. In synovial fluid analysis, important thing is gram staining and cultures will be negative. Gram staining will be negative. This helps you to rule out septic arthritis. Negative bifringence crystals. You need to remember this. This is suggestive of an gout. Positive bifringence crystals, if they are present, that is a pseudogout. Get an X-ray done and get urate levels or uric acid levels. The urate levels, you need to be cautious in an acute episode. In an acute episode, someone who is having a gout, it might be on the lower side or might be in the normal range. Why? Because the uric acid has got deposited into the joint space. So what you are measuring is in the serum. So the serum values might be in the normal range or might have been reduced also. So it is advised that once the acute episode has finished, then get the uric acid levels. Do not get it done during the acute episode. Treatment of choice is NSAIDs. If something is contraindicated, then you can use an colchicine. You can also use intra-articular corticosteroids, or basically in the joint space, you are infiltrating the steroids. This is not very commonly done. Commonly, the most choice of drug is NSAIDs. You need to always have a closer look in the stem of the question. Have they given any contraindication for NSAIDs? If they mention any contraindication, then the next choice becomes colchicine. You will be selecting the colchicine. Pseudogout. Pseudogout, contrary to the gout, doesn't involve the small joints. Small joints are mainly seen in the gout. Pseudogout involves the larger joint, especially the knee. You can see the knee here, the joint itself, you can see it is inflamed, red color skin is there. There is some amount of swelling also is present. What you do is, again, like an gout, you get an synovial fluid analysis done. Here you find an positive bifringent crystals, which is very important. X-ray might show destructive lesions like an osteoarthritis. That's why you get an X-ray done, but it's a synovial fluid which helps you to diagnose. Treatment is similar to the gout. You treat it with NSAIDs. How to differentiate between gout and pseudogout? In gout, the composition what you're seeing, that is the negative bifringent crystals what you're seeing, is made up of monosodium urate. In pseudogout, positive bifringent crystals, what you're seeing is made up of calcium pyrophosphate and it appears needle in shape. So this one, what you're seeing is the needle in shape, what you're seeing. This one, what you're seeing is a polymorphic or rhomboid state, what you're seeing. Remember that pseudogout is interchanged with the name of calcium pyrophosphate also. For example, gout can be also be called as a monophosphate urate disorder. So it can be interchanged and used in options. They usually give as calcium pyrophosphate, like in last diet and previous to that one also they had given calcium pyrophosphate instead of mentioning pseudo gout. So be aware of it. It can be interchanged names. It means one and the same. Ankylosing spondylitis. Ankylosing spondylitis is a group of disorders which is associated with HLA-B27. All right. So what are the manifestations? What we are seeing here? They are the group of manifestations. Different organs can be involved. For example, you can see anterior uveitis, Achilles tendonitis. You can involve the spine, resulting in ankylosing spondylitis. So when I am discussing with anterior uveitis, I'll be telling again that it is an HLA-B27. You can see the complications like an ankylosing spondylitis, inflammatory bowel disorders are associated with HLA-B27. So I'll be discussing this again in gastroenterology and telling you that it is an HLA-B27. So multiple things are associated. So someone who has an ankylosing spondylitis can have an anterior uveitis. Someone who has an anterior uveitis can have an plantar fasciitis. So they are interconnected disorders. What do you need to remember? How is the presentation? Usually this is seen in men, okay, in a quite younger age group, they present with an back pain. Okay, if it is already discussed, they will be telling that I have ankylosing spondylitis and worsening of the pain. That's why I presented to the emergency department. Not as an initial presentation, they come to the emergency department. What do you need to remember? Okay, sometimes not diagnosed. There is an underlying ankylosing spondylitis not diagnosed. Suddenly he has come in with, I had this back pain for a couple of years. I have just ignored it, taken over-counter drugs. Now I have a severe back pain. That's why I come to the emergency department. What has happened? What has happened is in ankylosing spondylitis, the bone becomes brittle and the joint spaces are decreased. They join each other and form an bamboo spine. This bamboo spine is quite brittle. Even a trivial injury, someone pushes from the behind, they can have a fracture. So even a trivial injury can cause a fracture in ankylosing spondylitis. That's how they present. They present with a fracture. If there are known case of ankylosing spondylitis, then what you'll be doing? Immediately scan them. That is a red flag what you are having. So the complication they present with not an primary diagnosis. Underlying cause might not be very clear. They might say someone who has an anti-uveitis has come in with a lower back pain. What are you thinking? There might be a fracture because this patient can have an ankylosing spondylitis. A trivial injury can trigger and fracture. That kind of questions have appeared previously, so you need to be aware of. Reactive arthritis, previously it was known as Ritter's disease, so any of these terminologies can be used. They classically present with a triad of urethritis, conjunctivitis, arthritis. Okay, so the inflammation of the joints, of the conjunctiva, and of the urethra they can present with. Most commonest organism is chlamydia, Shigella, and Salmonella also can cause it. How do you treat it? This is a bacterial infection, so requires an antibiotics. Along with there is pain because of the inflammation, painkillers you need to prescribe like NSAIDs. Now we are entering into the carpal tunnel. First, the anatomy of the carpal tunnel, usually tested in the primary, but you need to be aware in your SBA exam also. Carpal tunnel is basically the structures which are enclosed by flexor retinaculum. This is flexor retinaculum. It attaches over the hook of the hamate and it is attaches over the trapezium. Inside the carpal tunnel, so it forms a carpal tunnel. Carpal bones are here. The superior structure is flexor retinaculum. Inside it, it has tendons. Okay, four tendons from flexor digitorum superficialis, four tendons from flexor digitorum profundus. Along with it, there is an flexor pollicis longus. The important structure is the median nerve, what you need to remember. This is the important structure, what you need to remember. The median nerve, what you need to remember. Because any pressure which increases in the compartment will cause compression of the median nerve and the pathology is seen. That's why it is important. So the structures we have already discussed. What in carpal tunnel syndrome, we call it. You usually see a median nerve injury. So now we will be learning about the nerve injuries. The nerve injuries which you need to be aware of is the ulnar nerve, median nerve, and the radial nerve. The hot one to be asked or the favorite one to be asked in the exam is the ulnar nerve. The special test of the ulnar nerve they can ask you on. Okay, but it doesn't mean the median nerve and the radial nerve doesn't appear in the exam. So be aware of all three nerves. First, we'll be looking at the sensory supply of the hand. Sensory supply, the blue color, what you are seeing, that is the thumb, index finger, middle finger, and half of the ring finger. On the palmar side, what you're seeing is supplied by the median nerve. What about on the dorsal side? On the dorsal side, tips are also supplied by the median nerve. What you need to remember, very important. And on the dorsal side, the thumb, the middle, the thumb, index finger, and half of the middle finger is supplied by the radial nerve. The most sensitive area to check for the radial nerve injury is here. First web space, what you need to check for. Next one is the ulnar nerve. Ulnar nerve supplies on the palmar side the little finger and half of the ring finger. And on the opposite side also, it supplies the little finger, half of the ring finger, and it also supplies little bit of the middle finger also. Few books says it doesn't supply, few books say it supplies. Gray's Anatomy says it supplies. So I put up this picture and I go with the Gray's Anatomy saying that it supplies. Then what are the muscles which are supplied by this nerve? What do you need to be aware of? Okay, the ulnar nerve. Ulnar nerve supplies the medial. Ulnar, you need to always remember that it is on the medial side. Okay, it is always on the medial side. Median nerve is always on the lateral side, you remember. Okay, so ulnar nerve always supplies the medial half of the flexor digitorum profundus. What is the function of flexor digitorum profundus? It is the flexion of distal interphalangeal joint. Of so as it supplies the only the medial half, so medial half supplies little finger and the ring finger. So only the little finger and the ring finger, this movement will be lost. That is a flexion of the distal interphalangeal joint will be lost. It also supplies flexor carpi ulnaris. It is easy to remember. Ulnar word is here, ulnar nerve, so it has to be supplied by the ulnar, so it becomes easier. This is basically an forearm muscles which helps the movement of the wrist joint that causes an flexion and adduction of the wrist joint. That is nothing but ulnar deviation it causes. What about the median nerve? Median nerve supplies rest of everything. Flexor digitorum profundus, lateral half of the flexor digitorum profundus, flexor digitorum superficialis, flexor carpi radialis. All this is supplied by the median nerve in the forearm. What about in the hand? In hand, the median nerve becomes here. The thing what you need to remember is the median nerve. Median nerve supplies two lumbricals, which causes flexion of the metacarpopharyngeal joints and extension of the proximal interpharyngeal joints and the distal interpharyngeal joints. It supplies opponent's pollicis. Whenever pollicis comes, it means thumb. Okay, so just remember pollicis means thumb. In any tendon, if they are using pollicis means thumb. Opponent's pollicis, so opposition of the thumb. Abductor pollicis brevis, abduction of the thumb. Flexor pollicis brevis, flexion of the thumb. So it's easier to remember. In other sense, what you need to remember is these are the muscles which usually makes the thenar eminence. In your hand, the thenar eminence just below your thumb, what is present, mainly because of this nerves, supplies the thumb. Ulnar nerve supplies rest of all the muscles. It is not very important to remember which one supplies which. If you can remember, it's well and good. If you cannot remember, if you're having difficulties, you need to remember the lesions, what we'll be discussing here. Before we go into the lesions and what pathology, what you'll be seeing, the thing what you need to remember is there is an easier way to test in your practice. Okay, you can remember the common game which is played is rock, paper, scissors. Okay, in that way you can check it. If he's able to make and rock, that is able to make and fist, then median nerve is intact. If he's able to make and seizes this position like an Caesar, then ulnar nerve is intact. If he's able to make an OK sign, then anterior interosseous nerve is intact. If he's able to extend all his fingers as shown here, then ulnar nerve is intact. This is an easier way to apply to rapidly make a diagnosis in the emergency department. You can use rock, paper, scissors. Okay, is the science. This is usually put up. This is has been recently come in the RCM learning. They are also kind of promoting this. Now we'll go through the individual nerves, the median nerve, the ulnar nerve, the radial nerve, what we'll be discussing, what you'll be seeing in these lesions. It lesion depends on where is the lesion, where is the median nerve is injured. Is it injured in the wrist or is it injured in the forearm? If it's injured in the wrist, what will happen? If it's injured in the wrist, there is loss of sensation. We are already aware of where is the loss of sensation by looking the previous diagram. So that one I'll skip it. Along with it, there is weakness of the thenar eminence. What will happen? He's unable to abduct and oppose the thumb against the resistance. What you need to remember, that is very important. Proximal forearm. Addition, if the nerve injury is in the proximal forearm, addition to the sensory loss over the skin, over the palmar surface and on the dorsal surface, what we had discussed previously, and the thenar eminences, what we had discussed. Along with it, what else will be there? Weakness of the wrist flexion and pronation. Wrist flexion means palmar flexion, what we are talking about. This is the pronation that will be lost. Loss of flexion at distal interpharyngeal joint of all the fingers except the little finger. Okay, all the fingers, distal interpharyngeal joint flexion will be lost. Flexion of the proximal interpharyngeal joint of only index and middle finger will be lost. You need to remember this. This is important because of the nerve supply, because of the muscles which are supplied here. Distal interpharyngeal joint flexion, because of what muscle it happens? It happens because of flexor digitorum superficial, flexor digitorum profundus. Profundus is what here, because the lateral part of the middle part of the profundus is supplied by the ulnar nerve. The lateral part is supplied by the median nerve. That's why little finger is paid here in the flexion of the distal interpharyngeal joint. What happens here? Loss of flexion at the proximal phalangeal joint. This is the proximal phalangeal joint. Only index and the middle finger, it is lost. It is intact in your little finger and in your ring finger. That's why whenever you ask this patient to make a fist, they make like this fist. This fist is known as Benedict sign or hand of Benedict. This Benedict sign is only seen, remember this, only seen when you ask them to make a fist. Okay, if you're not asking them to make a fist, it appears like a normal hand like yours and mine. When you ask them to close your fingers and make a fist, they'll not be able to flex at the proximal interpharyngeal, at the proximal interpharyngeal joint and at here distal interpharyngeal joint. That's why it remains erect. That is very important for you. Ulnar nerve injury. Ulnar nerve injury, few things you need to remember here. Palmar interosseous will result in finger adduction. So away from PAD you can remember as PAD. Palmar introitus will cause loss of finger abduction. Okay, spreading of the fingers. If the fingers are closing each together, then dorsal introitus is lost. You can remember as an dab. Dorsal introitus will cause abduction of the fingers. This can be tested with an card test. You're placing a card in between the fingers and trying to test how is the strength. If there is decrease in the strength of the intraosseous muscles, then it is a positive test. Another test what you can use, this is known as card test. Remember, they can test you in the exam. This is known as card test. The other test which is commonly tested is known as Froman's test, multiple times asked in the exam. So remember this name. What you're looking here is there loss of thumb adduction, adduction, what you are looking out for. What you are doing here is you're asking them to hold a card. Okay, if there is a flexion at interpharyngeal joint, then you are suspecting there is an ulnar nerve injury. If there is no flexion at the interpharyngeal joint, then it is a negative. Ulnar nerve is normal or intact. Now let's see if the nerve is injured at the level of wrist. What will happen at the level of wrist? Similar to that of the median nerve, what you need to remember. There's loss of sensation in median nerve also. If there is loss of sensation, we are aware of the sensation. Then in median nerve, it is the thenar eminence muscles which are involved. Here is the hypothenar eminence muscle is lost. Their thumb functions are lost because of that. Here, the little finger functions of abduction, flexion, and aposes is lost. So easy to remember, it's just opposite. This comes more on the medial side is the ulnar nerve, and the lateral side is the median nerve, what you need to remember. Next thing is weakness of the intraosseous muscles will result in unable to abduct or adduct the fingers, all the fingers. Lumbricals, it just supplies the third and fourth lumbricals. It just supplies the third and fourth lumbricals, what you need to remember. Because it just supplies third and fourth lumbricals, the little finger and the ring finger, there is extension at the this joint. What is this joint is known as metacarpopharyngeal joint, and there is flexion at the proximal interpharyngeal joint. So flexion at the proximal interpharyngeal joint and extension at the metacarpopharyngeal joint will result in an hand or a shape known as claw hand. This will be present at the time of presentation itself. You need not ask them to make a fist at all. They will have a claw hand when you're seeing them directly at the vision itself. They have the claw hand. Okay. In Benedict sign is different. When you ask them to make a fist, then you have the claw hand or the Benedict sign. Here the claw hand is present at the time of presentation itself. You need not ask them to make a fist. The differentiating factor what you need to remember. There is something known as ulnar paradox. What is ulnar paradox? If the nerve injury is more proximal, okay, that means if the nerve injury is in the forearm, it is more proximal the nerve injury is. This claw hand, what you are seeing, will start disappearing. So usually what we think more proximal, that means the nerve is injured at the level of forearm, at the arm, the injury must be very bad and the clawness should increase. It doesn't increase. It will get lost. The clawness will go away. This is known as ulnar paradox. That's why they are calling it as an ulnar paradox. Why does this happen? This mainly happens because flexor digitorum profundus, a branch comes out of the ulnar nerve in the forearm. So the flexor digitorum profundus also gets involved. Flexor digitorum profundus is important. Why is it important? Because of this action, there is flexion at the interpharyngeal joint. So this flexion, what you are seeing, the flexor digitorum profundus should be intact. If that is not intact, then this flexion will be lost. If that flexion is lost, the clawness will be lost. This is known as ulnar paradox. To make it very simple, if the injury is more proximal, the clawness will be lost. That is known as ulnar paradox. This is because of loss of innervation of the flexor digitorum profundus. What you need to remember, that should be enough. So the more distal the injury is, the claw hand will be more obvious. The more proximal the injury is, the claw hand will not be more obvious. This is known as ulnar paradox because the flexor digitorum profundus nerve, the muscle will get involved and that will cause the loss of clawness. Radial nerve injury. Radial nerve injury, you do not see the wrist drop if it is at the level of wrist. You see it if it is at the level of arm in the groove, that is the groove of the humerus. If it's that level, at that time only you see this wrist drop. You see only sensory loss if the injury is at the level of wrist. Okay, this is mainly checked over the first web space. What you need to remember in the ulnar nerve. So ulnar nerve is quite simple. There is something known as Saturday night palsy. This mainly happens, the name came because usually on the Saturday nights, the people get drunk and they kind of sleep off on the chair. This will result sleep off in this position as shown here. This will cause compression over the radial nerve. Because of the compression over the radial nerve, there will be a rest drop. This is known as Saturday night palsy, very commonly tested in a primary, unlikely to be tested in SPA because this is not a very common presentation to be actually in the emergency department. If at all, if they're present in this manner, you're just symptomatically treating or you're just assuring that you will get back the function because it is just not the injury of the nerve, it's the compression of the nerve. So compression is relieved, so you will get back the function over the next few days. Do not worry about it. That is the treatment for Saturday night palsy. Otherwise, you're not worried about it. Radial nerve injury, the takeaway point is only at the level of arm you see the wrist drop. Otherwise, wrist drop is not seen. Only sensory loss is seen if it is injuries at the level of wrist. The sensory loss mainly you will be checking over the first web space on the dorsal surface. Anyone has any questions? Before we go into the recall questions, anyone has any questions, please do ask before we enter into the recall questions. All right, we'll start discussing the questions. You can type, if you have any doubts, please do type it along with the question number. I'll get back to you guys. First one, what we are having is an 18 years old male who sustained an injury to his right leg while playing football, was brought to the ED by his teammates. He complains of pain around the knee and the ankle joint. On examination, the patient's hemodynamic is stable and neurovascular status of the lower limb is intact. The X-ray of the knee and the ankle of the lower limb is shown below. What is the next best step they are asking? So what is the next best step you're asking here? So what is the diagnosis? What do you need to be aware of? So what is the diagnosis here? The diagnosis, what you need to see is there are two views what you are given. You can see there is a proximal fibular fracture. Along with proximal fibular fracture, you can see this joint space what you are having is not uniform, suggesting often dislocation. So a dislocation at this level, along with the fracture of the proximal fibula, is known as Miscellaneous fracture. Remember this Miscellaneous fracture, it is known as one of the favorite fractures to be tested in the exam. So what will be the next best step for the treatment of this patient? The next best step for the treatment of this patient is reduction in the emergency department. Why to reduce it? There is a dislocation, reduce it. Once you are reduce it, then what you're placing? You're placing them on and below. You need to place it on above knee back slab itself because there is a fracture here also. Above knee back slab needs to be done. After that, you are referring to the orthopedics. So remember, reduction in the emergency department is the first step what you need to remember in the emergency department. Young female present to the ED with knee swelling and pain for 4 to 5 days, which is worsening gradually. She denies any fever or trauma. She is not known to have any comorbidities. A synovial fluid aspirate was done and it showed positive bifringent crystals. What is the most likely diagnosis? Positive bifringence, whenever it comes, it is suggestive of an pseudo gout. Negative bifringence crystals is seen in gout. So the direct diagnosis they have asked, it is an pseudo gout is the diagnosis here. A 23 years old male came to the ED with complaints of pain over the midfoot. He feels that the horse, he fell from the horse while horse riding a few hours back. He denies any other injuries. On examination, vital parameters are within normals. Ecchymosis is seen noted over the plantar and dorsal surface of the foot as shown in the picture. There is an bruising which is seen in the midfoot. Whenever there is a bruising in the midfoot, and especially in the horse riding scenario, if it is, always suspect and less fracture. Okay, it's a Lisfrank's fracture what you're suspecting. Jones fracture is more on the lateral surface. It is the heel is the calcaneum fracture. First metatarsal fracture, it will be mainly here what you'll be seeing first metatarsal fracture. Base of fifth metatarsal fracture pain is here. So it is an obvious you can rule out and come to a diagnosis of an Lisfrank's fracture. An elderly patient was offloaded from the ambulance bay to the minor unit. He was reviewed by an emergency nurse practitioner. The nurse practitioner is asking you for your help to reduce the dislocated shoulder of the patient. The image of the injuries is shown below. What is the immediate step for the management of this patient? So what will be the immediate step? What you can see, there is a bruising over the back. There is extensive bruising over the arm and the forearm, what you can notice. And he is an elderly person, what is there? So as an emergency physician, the first thing for you is to do a primary survey and rule out is there any life-threatening disorders or life-threatening injuries. If there are any life-threatening injuries are present, you will immediately intervene. So doing a primary survey should always be your first thing. In medical cases, also what you will be doing, first you will be assessing airway, breathing, circulation. Once you're satisfied with A, B, C, D, E, then only go for rest of the diagnosis. Here, shoulder dislocation will come in secondary survey, not in the primary survey. Okay, so you're not worried about the shoulder dislocation here. You're worried about more life-threatening injuries. A 24-year-old male presented to the ED with complaints of left lower limb. He has a previous history of a road traffic accident which resulted in a left tibial fracture. A cast was applied for the same 2 days ago in the fracture clinic. He was taken on the counter painkillers without any improvement. What is the next best step? So what are you doing? They have put a cast here. So this is the limb. You are having a cast here. It doesn't allow the swelling to develop. If someone comes with a pain, with simple painkiller, the pain is not coming down, suspect and compartment syndrome. If you're suspecting and compartment syndrome, first thing is to remove the constrictions. What is the constriction here? The cast which is causing. So remove the cast should be the first thing. A 40-year-old male presented to the ED with complaints of pain and swelling over the right knee. He denies any temperature spikes or trauma. He is a known case of hypertension and diabetes. His regular medication includes lisinopril and metformin. A synovial fluid analysis was done in suspicion of septic arthritis. The blood report shows an positive bifringent crystals. What is the most likely diagnosis? This has appeared in September 2024 also, the last previous diet here. So what is the diagnosis here? Diagnosis here, positive bifringent crystals to pseudo gout. Pseudo gout is not given in the options, but it is given pyrophosphate arthropathy. It is one and the same. Calcium pyrophosphate arthropathy is also known as pseudo gout. Remember, they both mean the same. Do not get confused in the exam. Gout can also be known as monosodium arthropathy. They can call it as, it means gout. Okay, they can be interchanged. The right option here is the fourth one. A 21-year-old female came to the minors of the ED. She complains of an injury to the hand while she was cooking. She denies any other injuries. On examination, vitals are completely stable. No external injuries was noted. Which of the following is suggestive of a median nerve injury? They're just asking median nerve injury. We'll go from low to the up so that we make a diagnosis. Loss of sensation over the first step is known as radial nerve injury. It is. Loss of finger abduction. Finger abduction or adduction. Both functions are done by ulnar nerve because ulnar nerve supplies both dorsal interosseous as well as the palmar interosseous. Loss of wrist extension. Extension of the wrist joint is done by the radial nerve, or muscles are supplied by the radial nerve. Loss of sensation over the little finger. Little finger, that is the medial half. Medial half, we always remember it is the ulnar nerve. Loss of sensation over the index and the middle finger. This is the median nerve. So this is the right answer here. A 40-year-old male sustained injury to the left upper limb while working in a garment factory. On examination, the patient is completely stable. Deformity is noted over the wrist. That prompted you to get an X-ray, and X-ray is shown below. What is the likely diagnosis they are asking here? So we have a checklist when we are saying an X-ray. So what the checklist, first thing what I'll be looking at is the articular surface is involved. Yes, the articular surface is involved. I can see there is a fracture line here. Articular surface is involved. Next thing is, where is this fragment? Is this fragment towards the thumb or opposite to the thumb? It is towards the thumb it is present. So it is displaced ventrally. Articular surface is involved, so I'll call it as an Burton. As it is displaced ventrally, I'll call it as an reverse Burton. So the diagnosis here is reverse Burton fracture. So it is a reverse Burton fracture, fourth one. A 33-year-old male accidentally sustained an injury to the back of the foot as shown in the picture. The triath nurse has gained the IV access and given the painkillers. On examination, there is loss of sensation over the heel. What is the most likely nerve which is involved? They are asking. What you need to remember is close to the knee, there is an posterior tibial nerve which runs. Okay, it is closer to the knee which runs here. This is very difficult actually if you ask me. So it is the posterior tibial nerve which gets injured here. This is the posterior tibial nerve which is very close to the knee what will be present. So if this is here, it runs in this pathway, the posterior tibial nerve. So most likely if you get an injury or the lacerated wound, as you see over the Achilles tendon, suspect and posterior tibial nerve injury. So this is the posterior tibial nerve injury. This is the difficult one. Same thing might repeat in your exam. So be aware, this is not covered in the class. It is only mentioned here. That's why I'm stressing here. Be aware of this one. Few more things what I want you to be aware of is the nerve supply of the foot. Okay, nerve supply of the foot is important. The medial side is supplied by medial plantar nerve on the plantar surface, what I am talking about. Lateral plantar nerve supplies the lateral part of the plantar nerve. Heel is mainly supplied by the medial calcaneal branch. What you need to remember, it goes little bit posterior also. Sural nerve almost supplies from the lateral part from the knee up to the little toe. Saphenous nerve supplies from just below the knee. It supplies the medial part up to the medial malleolus. It supplies. What you need to remember, it is also important. Not tested, but can appear in the exam. A 6 years old child was brought to the ED by her mom. She sustained an injury to the wrist while playing with her friends. She complains of pain over the wrist joint. On examination, there is tenderness over the wrist joint. A X-ray of the wrist joint is taken and is shown below. What is the most appropriate management? Usually, arrow mark will not be present like this in the exam. So what you're seeing here is a buccal fracture. Why do I call it as a buccal fracture? Because there is only elevation of the cortex. There is no breach in the cortex, what I'm seeing. In this fracture, the management here is you are just placing on a splint and no follow-up is required. So the right answer is the first one. A 33 years old male sustained an injury to the right hand while he was working in the garden 2 days ago. He ignored it as he thought it is a minor injury. Since yesterday, he noticed an redness and swelling in the right hand associated with severe pain. On examination, the patient has severe pain on passive extension of the fingers. What is the most appropriate management plan for this patient? What are you seeing here? There is a sausage kind of finger is present, quite swollen. It looks inflamed. Along with it, there is a pain on passive extension of the finger. Keeping all this in mind, the diagnosis should come in your mind is flexor tenosynovitis. It's very important. Flexor tenosynovitis, what you need to remember. If flexor tenosynovitis is happening, what needs to be done? Immediately involve the hand surgeon so that they can explore and irrigate. That is the fourth option here. Refer to the hand surgeon so that they can do an IND. A 64 years old female has seen in the ED 4 days back for an lower limb soft tissue injury. She was treated with painkillers for the same and discharged as her X-ray was normal. Today, she presented to the emergency department again with worsening of the pain in the same limb. You're suspecting compartment syndrome. Which of the following is the earliest sign? The first sign, pain on passive stretching or pain out of proportionate to the injury and on passive stretching is the full phrase. What do you need to remember? So the right answer here is the second one. A 65 years old female has accidentally slipped and fallen on the outstretched upper limb. She sustained an injury to the wrist. There are no other injuries sustained. She complains of pain over the wrist joint. On examination, the primary survey is completely fine. No left-threatening injuries are there. X-ray is taken and shown below. What's the likely diagnosis? Let us see this X-ray what you're having. This is the ulnar bone what you're having, ulnar bone, and it is articulating with the lunate bone. Okay, where are the other carpal bones? Carpal bones, this lunate cavity looks empty. Nothing looks in front of the, or nothing appears in front of that. That means they're all pushed backwards. Once they are pushed backwards, this is known as perilunate dislocation. So the right diagnosis here is the perilunate dislocation. So don't get confused between perilunate dislocation and lunate dislocation. In lunate dislocation, the articular surface of the radius will be empty and lunate will be pushed towards the palmar surface. Here, an entire carpal bones will be pushed towards the dorsal surface. A elderly male sustained a trivial injury to his left lower limb a few days back. He complains of pain and swelling over the left knee and is associated with high-grade fever for a couple of days. On examination, the knee is swollen, erythematous, tender, and restriction of movements. Patient is febrile. You're suspecting septic arthritis. They're just asking what is the common organism here. Common organism for an septic arthritis or an osteomyelitis is the one and the same. That is Staph aureus. What do you need to remember? Young male involved in a road traffic accident was brought to the emergency department. On examination, is completely stable. An analgesia was administered. Image of the limb is given. What can you see in the image? There is flexion at the hip joint. So there is a flexion, what you can see at the hip joint. And at the hip joint, there is an internal rotation also you can see. And the hip and the lower limb is adducted. shifted. That means closer to the midline. Flexion, internal rotation, and abduction of the lower limb is suggestive of an hip dislocation. To be more precise, posterior hip dislocation. So the right answer here is posterior hip dislocation. What about femur neck fracture? Femur neck fracture, usually what happens, externally rotated, not internally, it will be externally rotated and limb will be shortened in the femur neck fracture. What about femur shaft fracture? Whenever there is a shaft fracture, a deformity is seen in the thigh. Okay, because of the displaced shaft fracture, usually deformity is seen. Sometimes there might be a pulsatile mass because of the active arterial bleed can be seen. A 29 years old male who has fallen down from his two-wheeler was brought to the emergency department. He sustained an injury to his right ankle. He complains of pain over the ankle joint and numbness over the foot. The patient is completely stable. On examination, the right ankle is deformed and the dorsalis pedis pulse is feeble. You cannot feel it. It is feeble. What is the most appropriate management plan? What are we suspecting here? We are suspecting an ankle dislocation. Ankle dislocation, usually we do not get an X-ray done. You can directly go ahead and reduce it. Okay, so in the emergency department, you're reducing it. But the NICE guideline says make sure the pain management is excellent when you're reducing it. It doesn't justify that you just do it without any pain management. So the reduction, there are two options are here in the ED. One is with the Entonox, one is the procedural sedation. Right one is the fourth one with the procedural sedation. Only with Entonox, it doesn't give enough pain management. Along with it, if there was an morphine IV painkiller, you can do it. Entonox and morphine in combination, you can reduce the ankle joint. If that is not given in the options, that's why we are selecting procedural sedation. A 44 years old male went out with his friends for a drink. He ended up binge drinking. This morning he woke up with a shoulder pain. He doesn't remember what has happened. On examination, examination of the shoulder joint, you see what is shown in the picture. What is the most likely diagnosis? This, what you are seeing, is known as winging of the scapula. This winging of the scapula is mainly because of thoracic nerve injury. The muscle which is involved is serratus anterior is the muscle which is involved. So the right answer is the fifth one. There are two winging of the scapulas to be more precise, and if you study more about it, there are two winging of the scapulas. One is known as medial winging of the scapula. Another one is known as lateral winging of the scapula. Okay, or winging of the scapula lateral, winging of the scapula medial. Mainly the muscles which are involved are different. Whenever it is a lateral, then the trapezius and rhomboid muscle which is involved. But it is a rare thing to happen. So that's why they have not asked any questions till now on the lateral uh, lateral winging of the scapula. All the questions which have appeared is on the medial winging of the scapula, that is the serratus anterior, that is the long thoracic nerve which is usually involved to cause injury to the serratus anterior, resulting in winging of the scapula, which is medial. So remember, whenever they give winging of the scapula, do not choose trapezius or rhomboid. Always go ahead and choose the serratus anterior or thoracic nerve. This is the winging of the scapula, what they will be testing you in the exam. A young female had an accidental spillage of hot water over, over the left upper limb for a few days back. Today, she presented to the ED with severe pain. She is a known case of migraine. She is not on any regular medication. The picture of the upper limb is shown below. What is the most appropriate management plan for the patient? What are we suspecting here? A pain which has got worsened. So we are suspecting here an compartment syndrome. Though it is as a hot water, I do not see any third degree burns and causing an scar here and thinking of an ischiotomy. So I'm not thinking of ischiotomy at all because pain is out of proportionate here and I do not see a third degree burn. So I'm thinking of an compartment syndrome here. In compartment syndrome, treatment of choice remains fasciotomy. But if they would have given is what is the next best step as the option here, and there was one more option as to measure the intra-compartment pressure, then the next best step will be to measure the intra-compartment pressure. That is the important thing. Because they are not given that here, so we are choosing the fasciotomy. Why is it important to measure the intra-compartment pressure? Because we'll be subtracting from the diastolic blood pressure, you'll be subtracting the intra-compartment pressure. If it is less than 30, then only we go ahead and do fasciotomy. A 38 years old fell down while jogging this morning and sustained an injury to his right lower limb. He complains of pain around the knee joint and an X-ray of the knee and the ankle is shown below. What's the most likely diagnosis? So straightforward, they're just asking about the diagnosis here. Diagnosis, there is a fracture here. There is a proximal fibular fracture. Along with there is a dislocation which is present because the joint space is not uniform here and here. If you compare it, this is known as Miscellaneous fracture. Remember the treatment Miscellaneous fracture. First, you will be doing reduction, followed by cast application, followed by admission. That is the steps what you need to remember. A 39 years old female has slipped and fallen down while taking a shower and she has sustained an injury to her hand. Also complains of pain over the hand. She denies any other injuries. You administer analgesia and X-ray is taken and shown below. What's the most likely diagnosis what they are asking here? Let us have a closer look of the X-ray here. In the closer look of the X-ray, if you are seeing here, what can be predicted? This looks very much parallel and it is not articulating with the hamate bone. And if I draw a straight line here and here and here and here, they are bisecting, but this one is not bisecting. Keeping all this in mind, we are suspecting an carpometacarpal dislocation of the fifth digit. It is not an scaphoid fracture, what we are expecting here. The scaphoid bone looks completely fine. Okay, this is the scaphoid bone, what you are seeing. Scaphoid bone looks completely fine. And this is the lunate bone, what you are seeing. It is completely fine. So it is not a scaphoid fracture. It is the carpometatarsal dislocation of the fifth digit is the right answer here. A 55 years old male came to the emergency department complaining of a pain and swelling over his foot. His foot has got caught in the stirrup while horse. This means where the foot goes. Okay. This is what usually is the mechanism of injury while horse riding. When they fall down, their foot gets stuck. The primary survey is fine. The foot X-ray is shown. What is the most appropriate management plan they are asking? Whenever this kind of injury they present with, always suspect and less Frank's fracture. Whenever you're suspecting and less Frank's fracture, they have given an AP view here. You can see the middle border of the second cuneiform bone is not in alignment with that of the middle border of the second metatarsal bone. But the history also kind of gives away the diagnosis here. So this is an list fracture. What we do for an list fracture, we refer to the orthopedic for the admission because it requires a surgery. That's all we do for the list fracture. So the right answer here is the orthopedic reference. Most appropriate management plan is the orthopedic reference and admission what you'll be doing. A 68 years old female slipped over a wet surface and has fallen down on an outstretched hand. While shopping in the supermarket, she complains of a pain and a swelling over the wrist. And on examination, patient is completely stable. The nurse has administered analgesia. The X-ray of the wrist is shown below. What's the most likely diagnosis? AP view, articular surface. There is no fracture in the articular surface. Looks fine here. Only there is a fracture at the distal radius fracture. In lateral view, what we'll be looking at is the displacement of this fragment. Usually, what happens? Usually, radial radius usually is tilted slightly on the volar side. The tilt is completely lost. It has become completely straight here. If you're seeing it has become completely straight, that means it is displaced opposite to that of the thumb. That means it is the dorsal surface. It is displaced, suggestive of an Colles fracture. So this is an Colles fracture what you're having. 51 years old male, while going downstairs, sustained an inversion injury to the foot. Inversion injury. Why we are very much prompt of inversion injury? Because peroneus brevius gets stretched. It is attached to the base of the fifth metatarsal bone. So here only you are suspecting in base of the metatarsal bone. X-ray is given. You are looking base of the fifth metatarsal bone. Fracture is present. So it is an avulsion fracture of the base of the fifth metatarsal bone. So the mechanism of injury itself, half of the time it gives away the answer. Do not get confused with the Jones fracture. Jones fracture comes here. A 24 years old male unknown case of primary seizures presented the ED with an episode of GTCS, which lasted for less than a minute's time. The patient has missed his regular medications for seizures. He complains of shoulder pain. Therefore, X-ray has been taken. What's the most likely diagnosis? Most likely diagnosis, it looks like an light bulb. It looks like a light bulb. It is known as light bulb sign also because it is uniformly round here, suggestive of an posterior dislocation. Posterior dislocation is also known as posterior glenohumeral dislocation. So the right answer is the first one. A 40 years old unknown case of rheumatoid arthritis came to the ED, tripped over the footwear and has fallen down. On examination, patient is unable to adduct his fingers. Adduction or abduction of the fingers is supplied by the ulnar nerve. So you're suspecting an ulnar nerve injury here. What other findings can be seen on the examination? They're asking. What other you can do it? Tinel sign. What is Tinel sign? Tinel sign is tapping over the wrist. Tapping over the wrist will increase the pressure in the compartment syndrome and will cause numbness in the distribution of the median nerve. So this test is done to see the any median nerve injury is there. So remember, they might use it in some of the questions. This test is done to suspect or test for the median nerve injury because of an carpal tunnel syndrome. Foreman sign, yes, it is seen in the ulnar nerve injury. Wrist drop, it is seen in the radial nerve injury. Loss of opposition of the fingers. Anyone loss of opposition of the fingers, what are we suspecting? Median nerve injury again. Okay, loss of sensation over the little finger. Little finger, anyone which little finger is again the ulnar nerve, what are we suspecting? Loss of sensation over the little finger is again ulnar nerve, what we are suspecting. T-nail test is again. So what other findings can be seen on the examination of this? There can be loss of sensation. Sorry, this is the index finger. Index finger is the median nerve. Sorry, I misspelled it as a little finger. So this is again median nerve. This is again median nerve, loss of opposition. Wrist drop is the radial nerve. Tinel test is the median nerve. So the right diagnosis here is the format sign, which is only seen in the ulnar nerve. So this is the format sign. Whenever there is an flexion at the interphalangeal joint, then format sign is positive. A 40 years old male sustained an injury to his hand a couple of days back. He didn't seek any medical help as he thought it was just a minor injury. He presented to the emergency department this morning with swelling and redness over the injury, which is spreading. On examination of the patient, the pain on passive extension of the fingers is seen. What is the most likely diagnosis? It is a very straightforward, very much similar to the previous one. Here, they have directly asked for the diagnosis. Pain on passive stretching is present. A minor injury was there. Then the diagnosis becomes flexor tenosynovitis. The signs what we look out for is known as Canavel signs. What are the Canavel signs you need to remember of? Tenderness over flexor tendons. If you palpate here, flexor tendons, tenderness will be there. Sausage kind of fingers, symmetrical swelling will be seen. Finger held in the flexion position, which is seen here again. Whenever you try to extend these fingers by yourself, that is passive extension, they'll have severe pain. These are all known as Canavel sign. A 57 years old male was involved in a road traffic accident. He was sitting in the front seat, and during the accident, his knee collided with the dashboard, resulting in the knee injury. The primary survey is fine. X-ray is taken. Common structure injured in this type of injury. So, what is the diagnosis? What you are having on the X-ray? It is the posterior dislocation of the knee. What is there? It is a straightforward X-ray, posterior dislocation of the knee. Whenever there is a posterior dislocation of the knee, closer to here is the popliteal artery. Usually, it gets injured. So, the popliteal artery is the structure what you need to really look out for. A 24 years old male was involved in a bar fight. He sustained an injury to the right arm as it got stuck by an iron rod. He denies any other injuries. On examination, the patient is completely stable. You gain IV access and give analgesia. X-ray of the shoulder is shown below. What is the most likely neurovascular injury you are suspecting in this type of injury? What is the injury here? It is a shaft fracture of the humerus. Whenever shaft fracture is there, you are suspecting a radial nerve injury because radius runs very close to the humerus here. Behind there is a groove, it runs very close to it. So you're suspecting a radial nerve injury here. What is the abnormality seen in the picture they are asking? This was not supposed to be asked because this is a chronic condition what you're seeing here. So what are we seeing here? This, which is the flexion at the flexion at the proximal interphalangeal joint and extension at the distal interphalangeal joint is known as Bottinier's deformity. That's what you are seeing here. This is also known as Bottinier's deformity. So the right answer here is the Bottinier's deformity, most commonly seen in rheumatoid arthritis. There is a swan neck also what you can see where there is a extension at the proximal interphalangeal joint and flexion at the distal interphalangeal joint. This is known as swan neck deformity. Just be aware of never has repeated. I don't think so they'll repeat again because these are the chronic conditions unlikely to be shouldn't be tested in the exam. Young male Young male has presented to the emergency department with a deformed elbow after falling from a bike. X-ray is shown below. The common neurovascular injury they are asking. X-ray is suggestive of an elbow dislocation. Whenever there is an elbow dislocation, the most commonest one is the ulnar nerve. So the right answer here is the ulnar nerve injury. Followed by the ulnar nerve injury, there can be an median nerve injury. This is the second commonest. Little bit rare or very rare is the brachial artery. Brachial artery also can be injured, but it is quite rare. So the most common one is the Alana. Elderly male presented to the MS department with complaints of lower back pain for 2 to 3 days, which is gradually worsening. On the counter drugs are not effective anymore, and he is requesting powerful painkillers. After examining the patient, you suspect disc prolapse at L5. L5 nerve root compression results in which of the following? This we have learned in our major trauma class. L5, L5, L5 supplies the dorsal part of the first web space. Okay. So loss of sensation over the first web space on the dorsal surface is the right answer here. L5. Previously, I think in another question, they have asked about S1. Also, what you need to be aware of. This question has appeared in September 24 diet. Also, what you need to be aware of. A 65 years old male sustained an injury to the knee as he struck his knee into the office door while he was coming out of the office. He is a known case of BPPV and multiple comorbidities are present and he's on multiple drugs. The patient is able to weight bear on the knee joint. X-ray of the knee is shown below. What's the most likely diagnosis? Anyone? What's the most likely diagnosis? The most likely diagnosis here is fibrous cortical defect. What is fibrous cortical defect? Whenever the bone is in the healing stage, it might be because of an old injury, it might be there. Okay, so because the bone is in the healing stage, you get lesions like this, what you're seeing here. This is known as fibrous cortical defect. Okay, it is which occurs in a maturing skeleton, often after an usually a torus fracture, what we call it. Twisting kind of torus fracture is present, or in children, it is the green stick fracture, which is if present, you're basically suspecting this fibrous cortical defect. Most of the time, it is an incidental finding. You're suspecting a fracture, you get an X-ray done, and there is a lesion like this. This is a fibrous cortical defect. Nothing needs to be done, and this lesion is a benign lesion, or this is basically seen because of the bone healing, what is happening. Nothing needs to be done. You are just ask them to take some painkillers, everything will be fine. Do not worry. This is an incidental finding what we had. This is not caused because of the trauma what you had. A 52 years old male works in a factory. He sustained an injury to his ring finger while he was working with an heavy machinery. An image of the finger is shown below. On examination, vital parameters are within normal limits. There is no active bleed. What is the most appropriate management plan for this? Let us break down and see what are we seeing here. Here, there is loss of soft tissue. So soft tissue is lost. And if you compare to then another finger, that is the sorry, this is the mid. So okay, this is the middle finger. This is the ring finger. What you are having. If you compare to the middle finger, there is large amount of soft tissue losses there. We are suspecting there might be some bone exposure also. Okay, if bone is exposed with a soft tissue injury, antibiotics will be required. So this patient requires an antibiotics. Good pain management. So analgesia is required. That is important. Analgesia is required. Okay, then you need to refer this because it looks like more than 1 centimeter of the soft tissue loss is there. So either hand surgeons or plastic surgeons you need to refer to. So we need to choose an option which has all these three. Here, ring block is there, antibiotic is there, but no referral is given. So we kind of rule out this. X-ray, yeah, you can get an X-ray done, tetanus, antibiotic dressing before referring to it. Yes, this can be there, but there is no pain management is present in this. So that's why we can rule it out. X-ray, tetanus, antibiotics before referring. Again, no pain management. Again, no pain management. Ring block. Ring block is a local anesthetic. We are infiltrating on the both sides. It helps with the pain management. Pain management is done. Antibiotic is given. Then you are referring to the plastic surgeon. Yes, that's why we are choosing the third one. Third one is the right answer here. A 66 years old female was going on a morning walk and has fallen down. X-ray they have given and they are just asking what is the diagnosis. X-ray, first we always look at the AP view to look at the articular surface. Articular surface is intact, so it is not a Burton fracture. Either a Smith fracture or Colles fracture, what you're suspecting. Then we are seeing the lateral view. In lateral view, the displacement. Displacement is towards the thumb, that is the ventral surface is displaced. So it is a Smith fracture what you're having. So the right diagnosis here is the Smith fracture. Again, what is the most common structured injury they are asking? We have a look at the X-ray here first. In the X-ray, what you are seeing here is this is the acetabulum. The head is posterior to it. This is the posterior dislocation of the hip, what you are seeing. In posterior dislocation of the hip, the most commonest neurovascular injury is the sciatic nerve, what is injured. Again, they have given an X-ray. They are asked a diagnosis. Let us look at the X-ray here. Okay, X-rays, does something looks abnormal. This is the scaphoid bone. This is the lunate bone. The space looks quite abnormal. Usually, this is the amount of space what is supposed to be. Okay, just look at the other carpal bones, the space. That space what we are expecting here. It is no, it is more than that space. This is known as David Letterman's test or Terry Thomas test or a Madonna's test. This is because of dislocation of scaphoid lunate bone. So the right diagnosis here is scaphoid lunate bone. A 26 years old was brought to the emergency department with an injury to the right ankle while playing in football. He denies any other head injuries or loss of consciousness. An X-ray of the ankle is shown below. What's the most definitive manage? The wordings are important. They are asking for the definitive management here. What is the fracture what we are having? Like this round off and labeled will not be there in the exam. Be aware. Lateral malleolus fracture, medial malleolar fracture, the posterior part of the tibial distal part of the posterior distal part of the tibia is fractured. This is known as posterior malleolar fracture. Combination of this is known as trimalleolar fracture. Trimalleolar fracture are extremely unstable fractures, requires surgery. So you're choosing an option which requires a surgery because they're asking an definitive management. So you are choosing here urgent surgery. Urgent referral to orthopedics for an ORIF is the definitive management. What is, if they have changed definitive management next best step, what will be the right answer here? Anyone, what will be the right answer if it is the next best step? It is the immediate reduction will become the next best step, the right answer, because there is some amount of dislocation is also present. This and this, if you see, there is a dislocation. So reduce it. So immediate reduction will be the right answer if they ask next best step. Again, they are asking most likely diagnosis on the X-ray here. It is kind of repeat question with the different wordings here. So there is an dislocation which is present at this level, and there is an proximal fibular fracture. Combination of this is known as Miscellaneous fracture. Straightforward repeat. This question has appeared in September 24 also, and previously also appeared, and it was a recall question which has appeared again. So what is the most common structured injury they are asking? What are we seeing here? There is an distal fibular fracture is present. There is a dislocation which is present. Okay. Along with it, there is no overlapping of the fibula and there is no overlapping of the fibula and the tibia. Whenever the tibia and fibula are not overlapping, there is a membrane here. We are suspecting this membrane to be teared. This membrane is known as interosseous membrane, also known as syndesmosis. So what are we suspecting? What's the most common structure injured here? Is the syndesmosis tear what we are looking, because there is no overlapping of the fibula and the tibia. A 31 years old sustained an injury to the knee while playing football. He complains of pain over the knee joint. There are no other injuries sustained. On examination, the patient is stable and X-ray is taken and the same is shown below. What's the most likely diagnosis they are asking here? We are not sure which X-ray, either this X-ray or this X-ray was given. Here, there is obviously a fracture. So it is a tibial plateau fracture what you're having. Okay, if they are given this X-ray, what are we seeing here? There is a fat deposit which is present. This is known as lipohematosis. Lipohematosis, presence of this is also suggestive of a tibial plateau fracture. So the right diagnosis here is the tibial plateau fracture. A 4 years old boy was brought to the MS department by his worried mom. Has a redness and swelling over the knee joint. The patient has started on the antibiotics by the GP and it was completed the antibiotics, but there is no improvement. In spite of completing a course of antibiotics, there is no improvement seen. X-ray of the knee is shown below. What's the most likely diagnosis they are asking? In the X-ray, what can we see? In the X-ray, we can see lytic lesions. Dark color bone, what you're seeing, dark color bone, what you're seeing. These are known as lytic lesions. So overlying skin infection was there. That is nothing but skin infection, cellulitis was present that has spread inside. So contagious spread has happened, resulting in osteomyelitis. So the right diagnosis here is osteomyelitis. They're asking which of the muscle is involved. So what are we seeing here? Winging of the scapula. Winging of the scapula is because of the serratus anterior muscle. Serratus anterior muscle is supplied by long thoracic nerve. What you need to remember. Do not choose trapezius or do not choose rhomboid muscles. Those are seen in winging of the scapula on the lateral. This is the medial what you are having. Unlikely lateral will be tested in the exam, which is a very rare thing to see. They're asking what is the next best step in the management. Doesn't matter what is the injury. Let us see in the X-ray what has happened. In the X-ray, there is a dislocation here because the articular surface of the phalanx and the metacarpal bone are not articulating. So thumb dislocation is present. So thumb is dislocated. Thumb dislocation is present. So what do? We need to relocate it back. Relocation, always I have told that ring block doesn't work. Do not give a ring block. You need to give a combination of an radial nerve and the median nerve block. Radial nerve and median nerve block is not given in the options. So what can be done? A procedural sedation can be done and done in the emergency department. Digital block doesn't work. Reduction in the OT, it will be an overkill treatment for this patient. You cannot just put a body strapping on this one without reducing it because they're asking the next step. A 20 years old came to the emergency department with an injury to the finger, which has sustained 3 days ago. He complains of severe pain and an image of the injury is shown below. What is the next best step in the management? 3 days. What is here what you're seeing? This is known as sublingual hematoma. Why do this patient have severe pain? Because blood is accumulating below the nail. That's why it is severe. We cannot drain it if it is more than 48 hours because it has formed a clot. That's why we need to do an IND. Why I'm telling it is more than 48 hours? It is mentioned here 3 days ago. That's why incision and drainage will be the right option here. If there is less than 48 hours, then we do an trephination. A 10 years old boy sustained an injury while playing football. He was brought to the emergency department by his coach. He complains of a pain and swelling in the foot, and the patient is unable to walk in the emergency department. X-ray is taken and shown here. What does the X-ray say? There is a fracture here. This is a calcaneum fracture. The calcaneum fracture or this kind of fracture is also known as os callis fracture. Okay, this is a new terminology what I'm using here. Os callis fracture. Remember, this is a calcaneum fracture itself. This has again appeared in September 24. 18 years old patient sustained a lacerated wound to the shin of the leg while playing rugby. There are no other injuries sustained. His immunization is completely fine. Patient is stable. How do you manage? Any lacerated wound over the shin, do not suture it. You will close it with sterile strips. Keeping it open can predispose to infection. Suturing shouldn't be done. Plastic surgeon will be a overkill here. Suturing with an absorbable, Vicryl is an absorbable sutures. Ethylone is a non-absorbable sutures. Never use an absorbable sutures for closing the skin. Okay, why don't we use an absorbable sutures to close and skin? Because to absorb, it takes 6 weeks. This is an foreign object what you're having. The suture material itself is a foreign object. Chances of infection are very high. Okay, for that reason, to close the skin, we never use an absorbable sutures. We always use non-absorbable sutures like an ethylene or silk, what you can use, or an proline, what you can use. Okay, that's the best thing what you need to remember. Close the skin with the sterile strips is the right answer here. Because the skin will be under tension, the wound healing will not be good if you suture it, if skin will go under tension. A 19 years old boy brought to the emergency department with complaints of pain and swelling and the elbow x-ray is given. X-ray is shown here. What's the next best step they're asking? Obvious fracture is present here. Okay, and it is displaced. So it requires a surgical management. So you need to refer them, immobilize it above elbow back slap, then refer to the orthopedic doctors. They're just asking what is the diagnosis here. X-ray. X-ray, you can see TBI is moved posteriorly and it is not articulating with the femur here, suggestive of an posterior knee dislocation. Posterior knee dislocation, closer to it, there is an popliteal artery which can get injured. They're just asking the diagnosis. So the diagnosis is posterior knee dislocation. They're asking which one of the following is seen in the examination of the shoulder. What are we seeing in the X-ray? First one we need to see. There is a posterior dislocation. Why I am saying? Because of the presence of light bulbs in on an AP view. So because of the posterior dislocation, what will be seeing? A palpable gap posterior to the shoulder. Do not get confused. Anterior to the shoulder. Anterior to the shoulder is seen in anterior shoulder dislocation. Posterior to the shoulder is seen in posterior shoulder dislocation. Young male present to the MS department with an absent ankle reflex and loss of sensation over the lateral border of the foot. What is the likely diagnosis? Which nerve is involved? Basically, what you need to suspect here. Lateral part of the foot. This is the lateral part of the foot. It is supplied by S1. So choose the option which has an S1 here. S1 compressive myopathy. What is here? And S1 is also required for ankle reflex, ankle jerk, ankle reflex. So S1 compressive myelopathy. A 44 years old male sustained an injury to the leg while walking on his farmland. He is a known case of diabetes. On examination, is stable. A puncture wound. This is important phrase. A puncture wound is seen over the leg. X-ray is taken and same is being shown below. Which one of the following complications the patient is at risk? There is already a puncture wound is present and there is a fracture is present. So what are we suspecting here? What is this diagnosis? It is an open fracture. Open fracture are susceptible for infection. That's why we always prescribe antibiotics here. So here, what are we worried about? Infection. Let's twist around this question a little bit. I will not mention there is a puncture wound over the leg. I'll just mention that the skin is intact. The skin is intact, what I mentioned. So there is no puncture wound, there is no communication. So it is not an open fracture. If it is not an open fracture, you can see close to the, where is the arrow here? Close to here is, it is tenting. Okay, the skin is under tension. It is tenting because the sharp edge of the broken bone is there. So it can pierce at any point of time. So skin giveaway will become the right answer. Okay, so remember that if the puncture wound is not mentioned, giveaway is the right answer. If the puncture wound is mentioned, because it is already the scene is given away, so it cannot be the right answer here. And it has become an open fracture. That's why the infection is most likely. So that's the differentiating factor what you need to remember. A 44 years old male works in a local factory. Today at work, he accidentally sustained an injury to the wrist. He complains of pain over the wrist, which is associated with the numbness in the index finger. His observations are as follows. X-rays shown below. What is the most likely nerve which get involved? There are few things. Numbness over the index finger itself is suggestive of a median nerve injury. Okay. One more thing is here is this lunate articular surface. This is pushed outwards towards the thumb. So this is an lunate dislocation. Lunate dislocation, the most common nerve which is involved or neurovascular structure which is involved is again the median nerve. So in two ways you can diagnose. Here also you can diagnose as a median nerve. Looking at the fracture also you can diagnose as in looking at the dislocation also you can diagnose as the median nerve. So the right answer here is median nerve. It has appeared in September 24. A 31 years old male unknown case of seizures presented to the emergency department with an episode of seizures. He complains of pain in this shoulder. He denies any other injuries. He skipped his regular medications as he was trekking. On examination, his vital parameters are normal. A deformity is noted over the shoulder. X-rays shown below. What's the most likely diagnosis? What you need to remember here is extremely abducted upper limb, extremely abducted humerus. Whenever it is present, suspect an inferior shoulders dislocation. It is a dislocation because this is the glenoid fossa. This is here. It is an inferior dislocation, obviously. This is the coronoid process. Just below the coronoid process is where the anterior dislocation will be. Do not get confused. Here you can see head is almost there. It is there in the chest wall. It's not below the coronoid process. Thus the differentiating factors. So extreme abduction and the head being in the chest wall is the inferior dislocation. If the head is below the coronoid process and not extremely abducted and not in the chest wall, then it is an anterior shoulder dislocation. So the right answer here is inferior shoulder dislocation. It is also known as flexio erecta. A 24 years old male sustained an injury to the finger yesterday while he was mending his bike. He presented to the ED with a severe pain over the fingers and his vital parameters are stable. An image of the X-ray and the finger has been given. So yesterday, so it is less than 48 hours. Okay. What are we seeing on the X-ray? There is a fracture of the tip of the distal phalanx. What we do for this management? Just in body stabbing should be fine. Nothing needs to be worried about. Why this patient is having pain? Because of the accumulation of the blood below the nail or in the nail bed. This is sublingual hematoma. It's more than 50% is involved. So that's why you need to do an trephination. Trephination can be done because it is less than 48 hours. So the right diagnosis here is trephination. The image of the ankle and the X-ray of the ankle is shown below. What is the most appropriate next step? X-ray, they have already got it done. Most probably, they can get it done on a faster pace. That's why they got it done here. This itself is suggestive of an ankle dislocation because gross deformity is seen at the ankle joint. Along with it, you can see the tibia is not articulating with tibia is not articulating here with the mortise at all. Okay. So what is the diagnosis? This is a knee dislocation. Sorry, I'm sorry. This is an ankle dislocation what you're having. So what we do ankle dislocation, try to reduce it in the emergency department. Emergency department, when you're reducing it, Entonox and morphine is the one plan. Otherwise, you're doing an conscious sedation. So either, or you can also give an Penthrox and do it. Penthrox is also known as methoxyfluorine. So you have three options as we are dealt in the class. Remember those things. A 41 years old has fallen down from the horse. His foot has stuck in the saddle of the footrest. He complains of mid-foot pain. Again, all is suggestive of a Lisfranc fracture here. On primary survey is fine. His observations are fine. X-rays shows an Lisfranc fracture. What is the mechanism of injury they're asking? The two mechanism of injury. One is crushing injury, a crushing mechanism of injury. They are given here. The another mechanism of injury is foot abduction and plantar flexion. This is the mechanism what you see when you try to fall down from the foot and foot gets stuck in the saddle of the footrest. Okay. Forefoot abduction with plantar flexion. That's why we are choosing this. This is not an crushing injury. Crushing injury is something is falling on your foot. Like a car has gone over your foot or some heavy object has fallen down on your foot. Like you're working in the gym and a heavy dumbbell has fallen down on your foot. This is the crushing injury. They're just asking here is what is the likely diagnosis? Again, let us break down here. There's no articular surface fracture is present. So it's not an Burton fracture. And the fragment is displaced towards the thumb. So we are thinking of a Smith fracture. This is a Smith fracture. So the right diagnosis here is the Smith fracture. A 9 years old boy has fell on the elbow with playing with his friend. He has brought to the emergency department. He has complaints of a pain at the site of the injury. Ibuprofen paracetamol has been given. X-ray is shown below. What is the likely diagnosis they are asking here? We have not yet studied about supracondylar fracture. We will again study about supracondylar fractures because it is mainly seen in pediatric age group. We are not covered pediatric orthopedics. But anyways, I cannot see obvious fracture line, but what can I see? I can see an posterior fat pad sign, which is always pathological. Whenever there is a posterior fat pad sign in a pediatric age group, I am suspecting a supracondylar fracture. In an adult, I am suspecting a radial head or neck fracture. So here, because it is a pediatric age group, I'll be choosing an supracondylar fracture. Do not worry, again, we'll be discussing this in the pediatric chapter. Which is the common structure which is injured? They are asking, let's see what is the X-ray diagnosis, what you are having. This is the acetabulum, what you are having. This is the head of the femur, which is dislocated. So there is a posterior dislocation, what is present of the hip joint, which is suggestive of an sciatic nerve injury. As the most common neurovascular structure which is injured is the sciatic nerve. This has again appeared in September 24 that 78 years old male complains of hip pain and difficulty in walking for the last couple of days. He gives a history of trivial fall 4 days back. On examination, the patient has a slight restriction of the movements he has seen by the GP who has prescribed paracetamol. On an hip X-ray of the joint is shown below. What is the most likely next step or the best next step what you will be doing for this patient they are asking. Let us see the X-ray what you are having. Elderly person fallen down. What are we suspecting? There might be a neck of femur fracture. Doesn't look like it. The articular surface looks completely fine. Shenton's line, what I'm seeing, looks completely fine. I cannot see any obvious fracture because the cortical surface looks completely fine for me. Along with this, usually A trivial injury can cause an anterior rami or a posterior rami fractures. Both looks fine. How do I see it? Pelvic inlet is completely round. Obturator foramen completely round. Shirton's line is fine. Looking at all this, I'm not suspecting any pelvic fracture at all. So X-ray is normal. Most probably the patient only has got paracetamol. That's why the pain has not come down. Given stronger analgesia should be the next best step. And it is always a good idea after giving a strong analgesia to refer to the orthopedics. Okay. No, sorry, not immediate referral. A follow-up with the orthopedics is a good idea. Not an immediate referral is not required. There's no indication for an immediate orthopedic reference. A follow-up with the fracture clinic is a good idea because the patient might have an hairline fracture. That's why you're not picking it up on an initial X-ray might be obvious after a couple of weeks. That's why follow-up with the fracture clinic will be a good idea. But analgesia should be the next best step here. They're asking what is the diagnosis depending on the X-ray. So let us see what is the finding we are having on the X-ray. There is the shaft of the radius fracture along with there is an distal radio-ulnar joint dislocation. This is suggestive of an Galeazzi's fracture. In an Montigia's fracture, exactly opposite it will be. There will be dislocation of the radial head dislocation with the fracture of the ulnar shaft will be present. That is known as Montigia's fracture. This is Galeazzi's fracture. Both are unstable fractures. Both require surgical management. A 69 years old female has fallen down from the stairs and sustained injury and a gross deformity is seen. Patient is stable. On examination, the upper limb is deformed with loss of radial pulse. So there is vascular compromise is there. Immediate reduction was done. Post attempt to reduction, the radial pulse is present. So no vascular compromise is present now. Before and after reduction X-rays are shown below. What is the most appropriate next step? What has happened? First, this was this vascular compromise. This you try to reduce it. It has not fully reduced, but whatever was causing the vascular compromise has got relieved. So what will be the next step? Do not try to reduce it. This is an unstable fracture. We tried to reduce it in the first hand here because there was an arterial compromise. There is a neurovascular structure was compromised. That's why we tried to reduce it. There is no more compromise after you try to reduce it. There is an obvious humeral shaft fracture which is displaced. It requires a nailing. ORF is required. So immediate referral to the orthopedic for an ORF is the right answer. Again, attempting, do not attempt it. It's an unstable fracture. Again, you got an pulse back, so do not reattempt it. Advice to fracture clinic. You can do an advice, but the better treatment will be referral to the orthopedic in this situation because there was an vascular compromise. Some movements can again cause vascular compromise. You're worried, so immediate referral to the orthopedic will be the right. Reassurance and discharge, no, wrong. GP follow-up, wrong. A 39 years old female has fallen down and sustained injury to the shoulder. She presented to the ED with complaints of a pain and restricted movements of the shoulder. The nurse secured an IV line and gave the painkillers. Vital parameters are within normal limits. X-ray is shown below. What's the most likely diagnosis? Again, light bulb sign. Multiple times we have discussed this. It is suggestive of an posterior shoulder dislocation. Straightforward question. Next one we are going here is a 44 years old male, a plumber by profession. Presented to the ED with a knee swelling and a pain for a couple of days. He denies any other injuries and his observations are complete fine. He's afebrile. The image of the knee is shown below. What is the most likely diagnosis? We are thinking of here some bursa might be involved. Osteoarthritis and rheumatoid arthritis are chronic conditions, cannot happen all of a sudden in a couple of days. So which is the most common bursa involved in a plumber who kneels a lot? It is pre-patellar bursa, and the most commonly involved also is a pre-patellar bursa if they're not given plumber also. So it is a pre-patellar bursitis what you are having. What we treat, just give some rest, and NSAIDs is the treatment of choice because it's an inflammation. We're not suspecting any infection because this patient is afebrile and their vital parameters are within normal limits. What is the next best step they are asking here? First, let us see what is the diagnosis. There is the radius, lunate, but lunate cavity is empty. So all the carpal bones are pushed backwards towards the dorsal surface. This is perilunate dislocation. What we do for perilunate dislocation, we ask the orthopedic doctors to come to the emergency department and reduce in the emergency department. You are not reducing yourself in the emergency department because it is difficult. We want an orthopedic to reduce it in the emergency department. So this is the right answer. We are not doing this in the operation theater also. We are reducing it in the ED itself, contrary to the lunate fracture, which is reduced in the operation theater. That differentiation factor you need to remember between a lunate dislocation and a perilunate dislocation. This question has appeared in September 24 also and previously also. An elderly female is referred by the physiotherapist to the ED. The patient complains of pain in the right arm for a few days and has got better with painkillers and physiotherapy. A X-ray has been done and is shown below. What's the most likely diagnosis? Pain not getting better with the painkillers also. Okay, this should be the red flag. Why it is not getting better? X-ray is shown here. What are we seeing on an X-ray here? This is what you're seeing on the X-ray here. This is what you're seeing in the X-ray here. This is known as periosteal elevation. Periosteal elevation is one of the findings of osteomyelitis. So do not forget, do not pick up normal periosteal healing here. It is unlikely because the pain is becoming worse. If the pain is becoming worse, it can't be a normal periosteal healing. Some pathology is there. In spite of painkiller, the pain is getting worse. That's why it is an osteomyelitis. What you need to pick up the answer as. A 70 years brought to the ED with complaints of pain and swelling in the elbow joint. He has fallen down while playing the football, sustained an injury to the elbow. X-ray is shown below. On examination, finger adduction has impaired. Doesn't matter what the fracture is. Forget about the fracture. Finger adduction or abduction is gone. You're always suspecting an ulnar nerve injury. So you can directly go ahead and pick the ulnar nerve injury as the right answer. From here, the questions what we are discussing have appeared in the September 2024 DAT. A 21 years old male while playing rugby suddenly heard an pop sound in his right knee, followed by swelling of the right knee. He has been struggling to walk since then and complains of pain over the medial side of the knee. No other injuries were sustained. On examination, he has tenderness over the medial side of the knee. What is the most likely structure? Anyone, what is the most likely structure involved? Tenderness over the medial side. So if this is the knee joint, this is the medial side and lateral side. Medial collateral ligaments comes here. So when you palpate, if you have tenderness, it's the medial collateral ligament. What you need to suspect? A knee swelling, a pop sound can be seen in collateral ligaments as well as anterior and posterior cruciate ligaments. It doesn't suggest one ligament over and another ligament. Meniscal injuries, can it be a meniscal injuries? Tenderness is seen over the joint space here in the meniscal injuries, not over the medial aspect. Another thing you need to remember in meniscal injury, the swelling is usually developed over the years, doesn't develop immediately. It takes, sorry, over the hours, doesn't develop slowly. So the right answer here is the medial collateral ligament. One of you asking why not refer to 65 question? Refer to the fracture clinic. You cannot, you need to reduce it. There is a dislocation is present. You need to reduce. Any dislocations needs to be relocated in the emergency department. Without relocating back, you cannot refer to them because they are asking next best step here. A 49 years old female, while on her usual morning run, suddenly experienced a pain back over her leg. She was unable to continue running and was brought to the ED by her husband. On examination, her vital parameters are fine, but she has weak plantar flexion. What is the most likely uh, what is the most likely injury in this patient? They are asking. It is an Achilles tendon rupture. Okay, plantar flexion is weak or unable to do it. It is an Achilles tendon rupture. What you need to remember, and it suddenly it happens. Achilles Achilles tendinopathy is a chronic thing. It is not because of this. Deltoid ligament tear is on the medial side of this is the stabilizers of your medial part of your ankle, not back of your not the back side of your ankle. Okay, that's what you need to remember. So it is an Achilles tendon rupture. What is the most appropriate management plan? They are asking again is the same history what they had given, which is pain on passive extension, kind of similar picture with fusiform swelling, some injury was there. It is suggestive of an flexor tenosynovitis. So the diagnosis is clear cut. What has happened in pre-exam is people got confused between option number 5 and option number 4. So which is the right one here? You shouldn't be doing an ultrasound guided drainage. You're not just putting a needle and doing it. You need to wash, flexure sheath wash. You need to irrigate it completely. So it's a rod insertion. You're opening it and you're irrigating it. There is no role of ultrasound involved here and requires an antibiotics. So the right answer here is the fourth one. Ultrasound guided drainage is not the right answer. It is not ultrasound what you use it. Here is basically you're doing an wash, completely irrigating and doing an wash, flexure sheath washout, what we call it. Which other injuries are you suspecting with this fracture? Or which is the neurovascular structure which is involved, they're asking. But let us see what is the fracture. Uniform articular surface, so not in Burton fracture. Fracture's edge is deviated dorsally towards the, deviated ventrally because it is towards the thumb. So I'm suspecting an Smith fracture. Smith fracture can cause median nerve injury. Colles fracture can lead to a median nerve injury because Colles fracture are sometimes associated with a lunate dislocation. Other fracture is reverse Burton fracture also can cause median nerve injury. All those can cause median nerve injury. So the right answer here is the median nerve injury. They're just asking what is the most likely diagnosis. They didn't even ask the treatment here. You can see there is a bulging of the cortex, sensitivity of a buccal fracture. Cortex is intact, only bulging is seen. So the right answer here is buccal fracture. Straightforward question again. The last one is which has appeared in Feb 2024. Uh, we do not have any solid information on about this question exactly it appeared like this or not. That's why it is in blue color what I posted here. So we'll go through the question. A 47 years old male has fallen down from a two-wheeler and sustained injury to the foot. He's brought to the ED in an ambulance. Then the patient is received in the major IV access is gained. The primary service completely fine. Deformity is located in the ankle joint. That's why you go ahead and get an X-ray done. What's the most likely complication they are asking? So what can we see here? There is an lateral malleolar fracture, medial malleolar fracture. Some amount of dislocation is present. Overlapping is still present there, so I'm not suspecting a syndesmosis there. Along with it, what are we suspecting here? There is a posterior part of the distal tibia is fractured. So it is a trimalleolar fracture. Okay, unstable trimalleolar fractures. What is the most common likely complications? Loss of sensation over the lateral side of the foot. So S1 is the lateral part of the foot. S1 or the sural nerve injury is unlikely what you are suspecting. Loss of plantar flexion is lost. Again, unlikely what you are suspecting. Dorsiflexion might be because whenever there is a dislocation or a fracture, there might be a distal fibular fracture also associated with it, which is known as Miscellaneous fracture. Miscellaneous fracture, whenever there is present, common peroneal nerve can be injured, resulting in an dorsiflexion loss or loss of dorsiflexion might be there. So we are expecting this to be the right answer. Loss of sensation over the medial aspect of the foot. Again, unlikely. Loss of sensation over the plantar surface supplied by the tibial nerve, two branches, medial and lateral plantar nerves, what it supplies it. Again, we suspect unlikely. But only with this much, where there is no fracture seen at the fibula side, there is no obvious literature to support it can be a common perennial now, but it is a good guess. If I was giving the exam, I would have chosen the dorsiflexion as the right answer. Okay, we do not have an good literature to back up the answer what I'm telling. For that particular reason, I have put up in the blue. But if you ask me, I would go ahead and select the dorsiflexion as loss because I'm suspecting a common perennial nerve injury because there might be associated proximal fibular fracture. That ends all the recall questions and completes the musculoskeletal chapter.